Next, we have Dr. Prakash sir on stage. Sir will be speaking on the cutting edge techniques of vitreoretinal surgery in myopic eyes. Over to you, sir.
Thank you, Anjana. Um, so my talk is on newer techniques what we are doing in myopic retinal surgery, and my job has been made very much easier by Dilish because he has described most of the surgical techniques that's currently used for myopic traction maculopathy. So myopic eyes are a peculiar group of eyes where they are at risk for many complications compared to normal eyes. There are complications which are specific to myopia like myopic traction maculopathy which you don't see in normal eyes. But all other complications that normally happen like an ERM, macular hole or a retinal detachment that happens in normal eyes also can happen in myopic eyes. But when they happen in a more severe level and they happen earlier in younger age group. So that is a anatomic problem that we face with myopia. And surgically, it is very challenging to do surgery in VR surgery in myopic eyes mainly because of these factors. One is the high axial length. So many times we cannot reach the posterior pole for the instruments may not reach there. The posterior staphyloma and an abnormal curvature, the radius of curvature is very less compared to normal eye. So when you move instruments, there is a high risk of touching the retina. Thin and atrophic retina makes it difficult, especially to do laser, RP atrophy. If it is there, you cannot do laser. And also it decreases the contrast so that we cannot see the retinal layers like you see in normal eyes. And degenerated vitreous, many of these eyes have schitic vitreous which leaves many layers of vitreous. Even if you feel there is a PVD, after you induce one PVD, then you will see there are multiple membranes, still vitreous membranes remaining. Then they have thinner sclera and abnormal scleral fibers architecture which makes a wound closure difficult, and as I told earlier, the lack of contrast at posterior pole. So we'll see few of these problems and how do we used to tackle previously and how do we tackle nowadays. So increased axial length is for all of us that's the biggest problem. So initially we used to use 20 gauge instruments because 20 gauge instruments are stouter, so they are also longer, so we could easily access the posterior pole. If you want to use small gauge instruments, remove the trocar so that you will get another additional 0.5 or 1 millimeter extra length. That will increase the length of the instrument. And another thing is to reduce IOP of the globe and press with the finger while the surgeon is operating. The surgeon presses on the globe through his the active instrument so that the globe goes, the sclera goes down and you can reach the posterior pole. Nowadays, all companies are coming with newer instrumentation. This is something developed by Topcon office system, where they have this kind of bend. The biggest problem was when you you have to align more vertically the instruments than in a normal eye. So when you align vertically, the biome lens, which we use a non-contact viewing system, comes in touch with the instrument, and then it becomes very difficult during surgery. So to avoid that, they have created these bent instrument, longer instruments, which are bent, so that the viewing system which is on top does not interfere in your surgery. Another way is to have long shaft instruments. These are again being developed by Alcon and they are launching it this year in India. So this also will take care of this problem. Then the other problem is epiretinal tissues visualization. So what we have been traditionally doing is chromovitrectomy, that is using dyes to identify various layers of the retina or the vitreous. So we have to use always tissue specific dyes. For vitreous we use tricot. We can see the multiple layers of vitreous, and for ILM in myopic eyes we routinely use BBG, but in ILM eyes it is in myopic eyes ILM does not stay in well with BBG and you may have to use ICG. ICG is slightly toxic than BBG, but still it is better to use ICG, and trypan blue is better for ERM. Newer techniques, we have intraoperative OCT microscopes mounted with OCT, 3D imaging techniques, which will make it better. Also, the other biggest problem is we usually inject with syringes which don't have a controlled injection. So many dyes get inside the macular hole, causing toxicity. So now we have newer devices which will have a controlled mode of injection and thereby avoid the toxicity. And we have also microscope mounted filters. We use amber filter for if you are using a billion green dye or a green for other dyes. And ILM peeling, again, is technically very difficult in myopic eyes. Mainly one thing, it is difficult to visualize. Second thing, it is your own instrument will block the view. While you are doing, you cannot see what is happening under your instrument. So it is better to start from the inferior or temporal quadrant so that you can see it better. And it is when you have to use an inverted flap or something, the flap usually goes away. So you can use a PFCL to reduce the mobility of the flap. But nowadays we have, for beginners at least, there are instruments like like finesse loop which can be used, which are very safe. You can scratch on the retina and raise the flap so that you can easily get an access to the ILM. Vitreous shaving again becomes difficult because of the risk of lens touch. So whenever there is a little cataract, it's better to take care of the lens, tackle the lens along with it. Sclerotomy leakage, we have now 27 gauge instruments which are very small gauge, as well as walled cannulas, which is again very useful in this case. This slide has already been covered by Dilish. This is from the Barbara Parolini classification. So basically what you have to understand is myopic maculopathy. There is two things happening. One is a tangential thing which will cause epiretinal changes like macular holes, lamellar holes, or full thickness macular holes, and that is tackled by vitrectomy. Then when you have in vertical anterior posterior change, that is the schisis developing, that is tackled with macular buckle. If there is a combination of these two, you will have to use a macular buckle along with vitrectomy. So these are this shows actually the natural course of myopic maculopathy. This is a picture on the top in 2019. Then you can see there is a full thickness macular hole that is slowly developing, and then few years later there is anterior posterior traction also developing. So that's the way it usually progresses. This was a lady who had 612 vision in right eye way back in 2018. Left eye had that time right eye had a mild schisis, as you can see here. But the left eye had a myopic traction maculopathy with a detachment, that is more of an anterior posterior thing. So an vitrectomy was done in that eye with gas injection, and that eye settled and had a postoperative vision of 636. Unfortunately, I don't have the pictures of that case, but later in 2023, she presented with drop of vision in the right eye, which she had 612 vision at that time. Now you can see there is again a macular detachment here. We searched for a break on OCT. OCT is very challenging in these cases. Many times due to multiple reduplication of echoes, you won't be able to interpret OCT correctly. So here we couldn't actually make out where the macular hole, where the hole was, which was causing the detachment. So here, since the problem was a macular detachment due to an epiretinal problem, that's a hole, we had decided to do a vitrectomy in this patient. So as I told her, usually it's if the lens is clear, it's better to preserve the lens because other eye is also myopic. So if you remove the cataract, then it becomes difficult to correct the patient after the surgery. So here the patient had a significant cataract, so it was decided to do a cataract surgery along with it. That also makes surgery very easier for us because without touching the lens, we can do base excision and other aspects of the surgery. So you can see the large posterior staphyloma here. This is the edge of the staphyloma and the myopic changes. So a complete vitrectomy was done with base excision. The challenge was in finding the break, where exactly the break is. So actually retinotomy was made, and brilliant blue-green was injected into the subretinal space. You can see the dye going under the subretinal space. Care has to be taken so that it doesn't go under the macula too much, and it also has to be completely evacuated so that it does not cause a macular dye. If left behind, it can cause macular toxicity. So once the subretinal dye is there, just gently over the disc area, wherever you are suspecting there is a break, you can just aspirate with the float needle. And as you aspirate, you can see the dye coming from that area. So that is the break because of the lack of contrast, because you are seeing bare sclera there. So you cannot normally make out the break unless you use this technique. So here I can see the dye is coming out through the hole, and so I identified the break which was cauterized, and then the surgery was completed after doing complete internal limiting. All the vitreous remnants were removed. And again here the problem is like many times you cannot reach the posterior pole, especially once you do a fluid air exchange, it's very difficult. So here instead of the biome, you can use contact lens. So the contact lens will avoid the touching of the instrument with the biome which is above the eye. The contact lens, since it is very close to the eye, you will have still working space for your long instruments. So the main thing is to remove all the traction. When there is no macular hole, then we do a fovea sparing ILM peeling, because ILM may be the only thing that is preventing a macular hole becoming full thickness in this eye. So we don't peel the ILM over the macula. A fovea sparing ILM peel is done. Meticulously ILM is peeled, and then a fluid air exchange is done. Complete dye is removed and the gas is injected. So that is the post-op picture of the patient. Patient recovered back 612 vision. And this is again a patient. Here you can see that you don't have a macular hole, you have only a submacular detachment. So here a macular buckle is being done. We are using a Morin Davin T implant. The biggest challenge is for retinal surgeons is to hook the inferior oblique. We usually don't have to hook the inferior oblique. We only do the recti, but here you have to take the inferior buccal. It has this element is passed under the inferior oblique, and here I am putting a infusion cannula as well as a chandelier, I mean as a light pipe, only to visualize the position of the buccal. No vitrectomy was done, no internal procedure was done, only to look at the position of where the buccal is going. So you can see the mound that is developing where I place a macula. So that helps me to position the buccal directly under the macula. So that's a post-operative picture on the right side. You can see the, it also decreases the myopia by about 2 diopter. But only problem is long-term studies, we have to see what happens to the, because already they have thin choroid, so the compression might cause more choroidal thinning and might cause an RP atrophy. So long-term follow-up is required, what happens to the vision, but right now the patient is doing well. This is again one more patient. Here you can see there is a macular hole as well as a detachment. So here the combination of both factors, anterior posterior as well as a traction is happening. So these are ideal cases for combined surgery where you will have to do a vitrectomy as well as macular buccal. So initial thing is to place a macular buccal. So as I told earlier, the inferior oblique is hooked, and this Morin Devin T buccal has 2 elements. One is a 240 like thing which is passed under the inferior oblique. Then it has got a T-shaped element which is which we place under the macula. So that is like doing any other buccal. So here I am doing the vitrectomy. You can see the large area of RP atrophy, and complete vitrectomy is done and ILM peeling is done. Here there is a macular hole already, so a complete ILM peel is done without fovea sparing. It's involving the hole. We have done an ILM peeling. And after the vitrectomy, the buccal is positioned. You can see the mount developing. The buccal is positioned. You can see the mount where this is the area where I am placing the buccal. We can see it. Once you confirm the position of the buccal, it is sutured onto the sclera, and the 240 element is tightened so that it is held from the other side also. After that, it's only a routine surgery. You do a fluid air exchange and put C3F8 gas. So these are few cases of myopic traction maculopathy which shows progression. You can see here it was initially treated for a CNVM, then developed a traction macular hole, then underwent vitrectomy. Then this is again one more case which has undergone vitrectomy. These are few cases done vitrectomy alone without buccal because there is no macular hole here. So this is one more case. So to conclude, we have to understand that these eyes are peculiar eyes where they have a higher risk compared to normal eyes to lose vision, not only due to other problems but due to retinal and macular issues also. So early detection is very important. You have to judiciously use whenever you see a patient of myopic macular degeneration, and if you have patient is complaining of any visual symptom, don't ignore it. Always do an OCT and see if there is anything going wrong. VR surgery is challenging, but newer technologies are making it better and more successful for these patients. Thank you.